We are live now.
Good evening, everyone. We welcome you all to OrthoTV Online, this new OrthoXpert Series, and today is the episode 9. This is a series which is brought to you by Centrum Joints and Mobility by Haleon. So, in this series, we introduce to you these young and dynamic orthopedic surgeons who have made a mark in their subspecialty. So, today we have my very good friend Dr. Abhishek Nerurkar with me, who is a consultant arthroscopy and orthopedic surgeon from Mumbai. He is attached to hospitals like Lilavati Hospital, PD Hinduja Hospital, Khar, SL Raheja Hospital of Fortis Associate, and Holy Spirit Hospital. And he is going to take us through the root of the meniscus. So over to you, Dr. Abhishek.
Thank you, Dr. Neeraj, and thank you, OrthoTV. So let me start my presentation. I hope it is visible.
Yes.
Great.
You can proceed.
So today I'm going to talk about management of meniscus root tears in clinical practice. So in day-to-day practice, what are we seeing? What are the patients in which you should suspect root tears? What are they? What is the importance? And how do you formulate the plan of management? So what should be the algorithm or thought process when you are treating these meniscus root tear patients? So we'll discuss in short about that and a very couple of short videos about how to do the arthroscopic repair as well. So what are meniscal root tears? If you see, they are defined as the tears that occur in the meniscus from within 1 centimeter of the tibial attachment. Okay, so they are basically biomechanically detrimental. So whenever there's a tear, the knee becomes biomechanically detrimental to have or undergo osteoarthritis. The occurrence of meniscus posterior root tear leads to loss of hoop tension in the meniscus, and that is why it results in meniscal extrusion. So if you see in the picture, and the top picture, this is the meniscus root tear, posterior horn root tear, and this is actually how you see in the arthroscopic picture, where the root is completely detached. So the meniscus is detached from the root, and this leads to the extrusion of the meniscus and completely a dysfunctional meniscus. Why should we worry about it? So tears of the meniscus root are about 10 to 21% of the meniscal tears in the literature, which is a significant proportion of all the meniscus tears. It has been reported that despite the contribution of these injuries to the degenerative joint disease, they often go undiagnosed. A lot of times, the tears of the root are not seen by the radiologist, and that is why it is very important and pertinent that you should train yourselves to see these MRIs and diagnose the root tears. These injuries tend to occur in deep squatting. There's often a rotatory component involved, particularly seen in lateral posterior root tears, and a high proportion of meniscal root tears have an associated ACL injury as well. So this is when you're talking about the traumatic root tears. Most of the time, the medial lesions that occur are going to be degenerative tears. So, traditionally what happens is medial tears are more often than not degenerative tears, whereas the lateral tears more often than not are going to be trauma-induced or, a RTA or a bike injury, so some kind of a traumatic event leading to a lateral meniscus tear. So typically these medial sided lesions occur in 4th and 5th decades of the life. And for so long they had been treated non-operatively and also sometimes in meniscectomy because the knowledge was not there. And that is why whenever the tear was seen in the meniscus and an elderly patient, most of the times the surgeon suggested to undergo meniscectomy, and that usually worsened the symptoms and created problems for the patient in the future. Posterior medial root tears have also been associated with patients who have high grade of osteoarthritis. So osteoarthritis, physiological virus of the knee joint, usually they predispose the knee to have medial meniscus root tears because there's abnormal loading of the medial compartment. And as a result, this degenerate meniscus, which has lost its elasticity, is not able to take the stress that is there and it gets torn. So these are typically degenerative tears that are occurring in 4th and 5th decades of the life. Meniscal root tests, but not always. So, more often they are seen in older patients, females, more obese individuals, and these tend to be the result of degenerative changes and a low energy mechanism. So, medial tests are usually occurring in low energy mechanisms. So, what happens in lateral tests? They are more often seen in younger patients, male patients, traumatic cases, and they are usually associated with ligamentous injuries. If you have seen the literature, then lateral root tests have been reported to be 10.3 times more likely to occur with ACL tests than medial root tests. And the presence of median meniscal root tests have been reported concomitantly. 8 to 12% of the ACL tests and 81% of the lateral root tests have been reported to occur with the ACL. So again, you have to remember, when you are actually undergoing or doing an arthroscopy for a ACL injury, two things you need to look for actively are your ramp lesions on the medial side and lateral root tear. So you have to examine the joint completely. Don't go and rush through the ACL, and then you will find out that there are problems that are left behind and usually lead to failures. So you have to know and actively look for it. Again, why these tears are important? Because menisci are fibrocartilaginous wedge-shaped structures. Okay, they are not to be removed because they are important in transmitting axial loads. They increase the joint congruency. They increase the contact area and stability. They decrease contact pressures, and they are also contributing to shock absorption and proprioception. So meniscus plays a very, very important role in knee kinematics. And the essential function is to dissipate forces across the joint because of the longitudinal orientation of the circumferential collagen fibers. What they basically do is to convert the compressive forces into circumferential hoop stresses. So always remember that meniscus are important, and this especially holds true in cases of lateral meniscus. Never sacrifice or compromise on repair for a lateral meniscus. So why root is important? Because root is vital for the meniscus to function. If you have a root tear, it is as good as not having a meniscus. So this is a completely a dysfunctional meniscus, because the meniscus extrudes out of the joint when there is wet bearing or when there is loading of the joint. So the detachment of the meniscus from one of its roots alters the knee kinematics, and has been demonstrated by biomechanical studies that it is equivalent to a total meniscectomy. So what happens is there is significant increase in the tibiofemoral joint contact pressures with the root test, and this leads to rapid degeneration of the knee joint. So if you have a meniscus tear patient who comes to you in acute stage, and if that patient is left alone, then more often than not, in 6 months to a year to couple of years, you'll find this patient coming back to you with significant arthritis or significant knee pain due to degeneration. So how can you suspect meniscal root tears in your clinic? Because it's pretty simple basically. Let's talk about these two different scenarios: middle age to elderly with a degenerative knee. Patient typically comes with a sudden pain at the back of the knee. They will tell you that maybe they have heard a popping sound, or you can ask them actively, because once you ask them, they will tell you that there was an event where they heard a sound, or where something happened and it suddenly started paining, maybe after a period of exertion, or maybe due to twisting or some event that happened, and then they find it very difficult to load their knee joint for some time. What happens typically, if these patients don't come to you, then in few days or a few weeks the pain improves, and but the difficulty in walking may still persist. They may later on, or in a subacute phase, come to you with difficulty in walking. They will usually tell you that, okay, I had this event, and after some time I'm feeling okay now. The pain has reduced maybe 70 to 80%, but still there is difficulty in walking. So they will typically point towards the inner aspect of the knee. That is very important. And the most precise test is to find the tenderness. So you find the tenderness, whether it is the joint line, you try to elicit whether it is the meniscus, but finding the tenderness and the location of the tenderness is most important. So now when you go to lateral meniscus, it is usually a different scenario. Younger patients, trauma, motorbike accident, we discussed this, associated with ligament injuries, and instability and difficulty in weight bearing would be very obvious. Again, lateral joint line tenderness, according to me, is very important to elicit. So examine the joint completely. Don't just examine one part of it, because you may miss these hidden lesions, and they are very important to correct in order to get a good long-term outcome. So what happens if you see this right side, the meniscus extrudes, and then the cartilage basically has higher contact forces, and this leads to the degeneration of the chondral surfaces. So Laprade has classified these root tears into 5 main types. Let's go through them one by one. First one is a partial stable tear. The second is a complete tear. So in a complete tear, the root and the meniscal posterior horn is completely detached from each other. The third type is the one in which there is a root tear and there is also a longitudinal tear, which may be a bucket handle tear. So this is the third type. Fourth is an oblique tear, and such tears are very difficult to approximate. And the fifth tear is a root avulsion tear. So here what has happened is, along with the meniscus, a bone fragment has also come off, and that is what you see here. So how to investigate? Don't be in a hurry if you see an MRI and a meniscus problem to just proceed with the surgery or offer them an arthroscopy. It is very important to do standing x-rays, and also the alignment films I'll show you again, because what happens is, if the arthritis is already progressed and if it is severe, then doing an arthroscopy and root repair may not make sense, and you have to change your plan accordingly. And there are a variety of surgeries that you can do, and I will come to that later on. But taking standing x-rays is very important. You have to see the stage of arthritis, you have to see the alignment, you also have to see the proximal tibial morphology. A lot of times there might be a proximal tibia vara. There can be something called as a pagoda tibia when the where the condyles are actually depressed and they are leading to varus. And all these things have to be addressed before in the management planning. So all my patients, especially the degenerative ones, not in case of the younger ones, but the patients who are in their 40s and 50s, they actually undergo a scanogram. A weight-bearing alignment film is very important to see what is happening, because you may have deformities in the femur, you may have deformities in the tibia, and you have to correct the deformities also, because if you don't correct the alignment, and if you just proceed with the repair of the root, then this root is going to fail. Alignment correction actually takes the priority over the repair of the root. So do these scanograms, do the weight bearing films, and then find out what is happening. If there's alignment issue, correct it. So the coronal plane posterior tibial slope also plays an important role, and especially in case of revision surgeries, you have ACL. This is in elderly, in younger patients, where you have ACL or any other ligament injury and the root tears. So it is also important to take these coronal films. What is more important is that you should learn to look at MRIs yourself. If you see 10 to 15 years back, when we started diagnosing root tears, at that particular point of time, lot of the radiologists used to miss root tests, and it was often underreported. And then we started discussing with the radiologists, used to call them and discuss the particular patterns. And gradually, nowadays, I think most of the radiologists are well, versed with finding out the root test. But you should have a look at the MRIs yourself. So what you see here in the first picture is typically a medial meniscus, which is coming, and there is a hyperintense signal here, which is actually a root tear. It's like a radial tear or a complete cutoff of that meniscus from the root. The second image that you see here is the white, the shadow that you see. It's also called as the ghost meniscus. So ideally, it should be hypointense, and this is a fluid signal which shows that this particular meniscus root is damaged. The third thing that you see is, again, this is the extrusion. So if you have a damaged root, then the meniscus will not stay inside the joint. And see, this is actually the MRI image, which is on lying down. So when the patient is loading, then obviously, it is moving out even more. And this is a completely extruded meniscus, which is actually leading to rapid degenerative changes in the knee joint. These are, like root-like lesions because we consider up to 1 centimeter as a root tear, and this is the posterior horn, somewhat a radial tear just at the junction of the posterior horn and the root. So you again see a meniscus which is there, and this is a discontinuity which is seen very near to the root of the meniscus. Again, this is the ghost sign. This is the normal meniscus, and on the left side you don't see the normal meniscus. So look for the MRI imaging yourself to understand what is happening. Another thing that you often see in meniscus tear or root tear is the subchondral edema. These are very painful knees, and more often than not, it may also be reported like subchondral fracture or sponk. But these are the changes that are happening because of abnormal loading of the medial compartment, and this is a reactive subchondral edema, which you often see either on the femoral side, also sometimes on the tibial side, when there are meniscal tears. So, how to decide the best plan for the management? Okay, for the lateral root tear, more they are more due to traumatic origins and in younger people, and the decision making is not that difficult. You know that you have to repair all the lateral meniscus root tears. However, the more important thing is because there are concurrent ligament injuries. So there may be ACL plus root tear on an extraarticular ligament and a root. So there are multiple things that can go wrong, or a cartilage injury as well. So the planning and sequence of the repair is extremely important because it's going to be a longer surgery, and you need to think about what you're going to do first and what you're going to second. So the sequence is very important to avoid intraoperative struggles. So in medial meniscus root tear, often because they come in a range where there is arthritis as well as the root problems and sometimes osteoporosis and all these issues that are occurring because of age, the decision making will require some amount of understanding of the pathology, and which will be actually individualized for that particular patient. So root repair is not the solution for all the patients. Okay, so I'm just going to enumerate what is there first. So the root repair can be done, isolated root repair can only be done in patients in which they come to you very early. So they don't have arthritis, they don't have varus, they have had a fresh root tear, and they come to you, and then you offer them to a surgery to them. Now, most often these patients may not turn up to you again because they gradually improve with time, and as a result, the isolated root avulsion repairs are very less in the clinical practice. So if you have a tear which is more, medially, then you may have to do side to side repair as as the radial tears of the meniscus are repaired. Maybe sometimes the stump is very short, and if the stump is short, then you may have to repair the meniscus. Uh, Wherever it is reaching, you have to repair. So it becomes like a non-anatomic repair. If you have a ligament issue, then again there are multiple options because you can do ligament reconstruction and root repair, or you can do an osteotomy and root repair. So osteotomy for basically slope correction, so that you balance the ligaments as well and the varus as well, and the root can be repaired at the same time. If you have a varus knee, then alignment correction has a priority and it precedes the root repair. So you have to correct the alignment. Then you can either do a root repair, or there are enough papers which actually tell you that even alignment correction will give you good benefit and good symptomatic outcomes in cases of patients with root tears, because you are primarily changing the load bearing of the knee joint, and when you do that, the root gets protected on its own. A lot of times you will have multiple cartilage pathology along with these root issues, and depending on the kind of pathology that you are dealing with, whether it's a large patch or a small focal defect, you can plan your treatment to do an abrasion chondroplasty or a ACI or an ORS or whatever cartilage procedure that is deemed necessary for that particular defect should be done along with the root repair. And sometimes the patient may come to you very late, when the knee is already degenerated, And mostly, if you see that whenever there's a medial root tear, these patients will come with a single compartment arthritis, and you may have to offer them something like a partial knee replacement. So this is a whole spectrum of surgeries that can occur, that you may have to consider when you're treating a root tear patient in a elderly patient. And what treatment you're going to offer to this patient is going to depend on what stage the patient comes to you. So, you should you should make a proper algorithm and then decide what is best for the patient. Sometimes you may get difficult repairs and non-reducible repairs. And then there are certain other procedures that are also described along with a medial meniscus root repair. One of them is called as a medial meniscus centralization, in which you fix the body of the meniscus onto the tibia. Sometimes you may have to create a ramp-like lesion. So you basically do a meniscocapsular release. So as you see in this particular figure, this meniscus cannot be brought to its original place. And then there is a release which is done along the meniscocapsular region up to the posterior horn. And then you are able to get this meniscus back to its original position. And as I said in the last slide again, sometimes you may have to undergo a non-anatomic repair. However, if you see the literature, the outcomes of non-anatomic repair are not as good as anatomic repair, and hence you should do your best to get the meniscus back to its position. So we are going to discuss only about the meniscus root repair in this particular surgical steps. I'm going to just briefly go through the surgical steps and try to make you understand what is the idea behind repair and repair technique, and what are you going to do, and how you should avoid mistakes while doing the surgery. The first and very most important step is to do the bed preparation before you do the tunnel. So once you decide that the location of the root, you decide the point, then you should actually prepare the bed. It's just like a non-union, because when you are dealing with a non-union, you cannot go and just fix it, and the internal fixation will not function unless you have prepared the whole non-union site. You have to remove the fibrosis, establish the medullary canals. So you have to prepare a bed. So the same thing happens in cases of your root repairs. You have to make the bed ready for the root to heal. That is the first thing. Second thing is a good tissue grass. So you nowadays, earlier we used to take bites with the help of the lassos, but nowadays I think everybody goes in with these anti-grade suture passing devices, which are very quick and very minimally, so they don't damage the cartilage. You can quickly go through and make 2 bites in a span of 2 to 3 minutes, and then do the pull-out technique. So take good bites and then you cinch them through. The third thing is you make a tunnel. So because I think it's a well-established technique to make a tunnel at the junction of the root at the origin. So basically the footprint of the root, and then you pass a suture shuttling kind of a thread, which will take these bites through, and then you tie it onto the tibia. So this is what essentially you are doing to repair the root. Let me go through a couple of videos. So this is a root tear. You've seen how the evaluation of the root is done, and then you use an anti-grade suture passing device. You pass a fiber wire or a fiber tape through it, and then you can use a luggage tag kind of a configuration, which is done here. You can also use a double cinch kind of a configuration, sometimes a crisscross configuration. So whatever is necessary for that particular tear and whatever is going to function the best is used. Then you use a root repair jig. It's a completely different jig because it has to go at the back of the knee, and it's a low profile jig. So you use it to for locating the footprint, and then you basically drill through over a bead pin. A 4 mm tunnel is established by endoscopic reamer. And then you pass a suture shuttling stick. The sutures are removed. Very, very important when you are doing this step, you have to make sure that there is no entanglement of the tissue of the sutures in the tissue. So either you can use a cannula or you can use a virtual cannula. And then once you pass, you see the stability of the root. Okay, and then tie it to the tibial post. So one more another video just to. Okay, so this is again a root tear. So there's a small stump left here, and sorry, right. The tunnel is already done. Then you pass through. Okay, so a complete evaluation of the root is done. The reducibility is checked, and then you take these antegrade suture passing devices and pass through your fiber wires. Again, the suture configuration or the loop configuration that you prefer. So this is how the meniscus root is secured now. And then you pass these sutures to the tunnel onto the surface of the tibia, where you can use your tibial root fix kind of a devices or a standard unloaded endo button to fix that to the tibia. So this is how it should look after the repair is done. And this is the fixation on the tibial side. So you can also use suture anchors. You have nowadays these newer root repair devices available in which you can do sliding knots as well. You also have something like uh, a, a suture anchor that is there. So multiple things of root fixation are available, but I think this pull-out technique is a well-established technique and it has been giving consistently good results in our patients. So the take-home message is, keep your mind open for root tears. You have to know it. You should know what is root tear and how to, what is the importance of these particular root tears in your knee preservation. Suspicion of root tears can be done on a proper history and clinical evaluation. So more often than not, my patients go to the MRI with the diagnosis of a suspected root tear. That in that way, even the radiologist is going to look properly for the root, and it's going to help in getting the right results for your patients. Look at the MRI images yourself so that you don't miss root tears. If you keep looking at it, it's very simple to find out the root tears on the MRI yourself. So in case you have suspected that and the report does not show, then you don't miss it. This is very important. Need for alignment correction precedes the need for root repair. So if you have a root tear and alignment issue, you can actually do a alignment correction and leave root, but the other way around is not possible. So you should not repair the root unless you correct the alignment. You have to look for alternative plans in arthritic knees. The whole purpose of doing this root repair is to prevent arthritis. And if you already have arthritis set in, or if it's a significantly arthritic knee, then don't attempt root repairs. Look for alternative plans that we discuss and check where you can go wrong, because meniscal root repair are very tricky surgeries and you can actually go wrong at various steps. So bed preparation is very important. Suture management is extremely important. Take the bites to the good tissue. Otherwise, it is going to cut out when you basically tighten. And stable knotting techniques or stable fixation is also very important, because you are trying a knots, and if they get loose, then the root may not function. The repair may not be as stable as you expect. So all these things are very important in getting the best result for your patients. Thank you.
Thank you, Abhishek. This was a very nice and comprehensive coverage, and the video was the icing on the cake.
Thank you.
So we have
Thanks.
some questions from Ortho TV viewers
Yeah.
who had insisted that we should do two investigations. So
Yes.
normally what happens is we do an X-ray, and many
Right.
times the patient is taking an X-ray in the supine position, so that turns out to be normal. And
Right.
then and the patient we are trying to conserve, and then finally they come back that the pain is not going, so we will do an MRI.
Right.
And then MRI shows a root tear. So you are saying that you should see it yourself. So which are the images which you should see? The sagittal, the coronal, which one will show the root tear,
Right.
which
So
will be
I'll tell you
perfect?
what, there are multiple things that happen. Sometimes patients actually come with MRI and then you have to explain to them that you need to do an weight bearing X-ray. Suppose if you are sending the patient yourself for the X-ray, then you have to insist on doing a weight bearing X-ray. But it's not always in your control. Sometimes the patient come with an X-ray. But I usually tell them that if you want to get the right treatment for yourself, you have to do a weight bearing X-ray. And uh,
Yeah, I only
can
stopped
you
the
hear me?
screen share. You can.
Okay, fine. Yeah. So you have to do a weight bearing X-ray. That is very important. And the second thing is scanogram. Scanogram is also very important here because you need to understand what is the alignment of the knee joint. If it is going in, say, 7 to 8 degrees of varus, you need to correct the varus. If you're not correcting the virus and repairing the root, then this is going to fail because the abnormal loading is still going on. And that is the primary reason why your root has been injured, or it has been damaged in case of degenerative knees. Uh, as as the question regarding the MRI images, as I showed you, all these images, can I go back to slide? Is it possible?
Yes.
One sec, because then I'll be able to show you exactly what I mean to say. So, see, this slide is very important. So here you are seeing a coronal section in which the meniscus is seen, and this is the root of the meniscus. So the posterior horn and the root, if you can see my arrow, and there is a discontinuity here. Okay, this is one section. This is a sagittal section in which normally this particular section meniscus should look as a hypointense image, so it should look black, but it's completely the fluid. This is the fluid signal that you are seeing instead of the meniscus. So this is in the coronal section. The third is again the extrusion of the meniscus, because the meniscus here has to be contained inside the margins of your the condyles, which is not seen here. So this is an extruded meniscus. This most probably is a sign of a chronic root problem. This is again a radial tear which is happening at the posterior root. So you see all these images, and then you have to train your eyes to see these sections. You can actually see root tears also on the axial cuts, but it requires a lot of understanding and persistence to see those images, find the exact level where the cut is. And then you can also see, I have actually not put that image in this presentation, but you can see that in axial images as well.
Yes, so that was a good explanation. Now we come to there are two types. What I had heard and what I have seen also is
Yeah.
that there are root tears can happen in a degenerative knee that is
Yes.
usually atraumatic or with a very minimal insignificant trauma. But
Right.
there are also root tears which can happen in younger patients, maybe 40 or maybe 45 or maybe below that age, where
Yes.
it could be traumatic.
Right.
So will you still get a scanogram done? And if you see something in the scanogram, do you still want to do an STO?
So usually traumatic tests are occurring in younger individuals, although they can happen in elderly people as well. So there is no fixed rule here, but more often the traumatic things or the root tests are going to happen along with the ligament injuries. It's very rare to have a person with a ligament injury with a degenerate knee. So although this scenario might exist, now it completely depends on the uh, how, if the patient is presenting you at very acute stage, then you probably are not going to do all these investigations, because you are looking at first settling the knee down. Once the knee settles down, then gain a little bit of range of movement. Then you assess the the problem. What are the ligaments that are injured? Uh, so once the assessment of complete assessment is done, then you think about the planning. And here you would actually not do unless there's a failure and the patient comes back to you for some reason. More often than not, these scanograms are not done, because you see the X-ray, you understand that there is not too much of a degeneration, and then you can actually proceed with the repairs. So the planning again depends on what all
Very
things are
younger patients, in
in
very
a
young
younger
patients,
in young
due
patient.
traumatic injury, you would not want a scanogram.
Yes, absolutely.
Yes. Especially if you see an ACL along with it, you may not need it.
Yeah, because then when there are traumatic situation, we are not looking at the degenerative tears. In
Yes, we are
degenerative
talking only
tears,
about young traumatic people.
yes, in
Sports injuries, for
degenerative
example.
tears, we need to look at alignment. In traumatic, we may not look at alignment.
So now let's go back to this. Now, supposing you have got this, there is a alignment issue, there is virus. Patient is maybe a middle age, say 45, 50 years old,
Yeah,
female housewife.
right.
You would want the ideal treatment would be an HTO with a root repair. Now there are two schools of thought here. People
Yes,
who do arthroscopy, they want to go all out, they want to do the root repair and HTO. People
true.
who don't do arthroscopy, people who are deformity surgeons, they will say if we correct the HTO, there is no need for the root repair because the root avulsion will settle down and heal on its own. What is
Right.
your take on?
So here what happens is I usually do an arthroscopy, yeah, primarily because what it gives me information about the other intra-articular structures. Okay, if you have a meniscus tear, or these meniscus are not only single isolated root tears. There can be a meniscal flap. There can be there may be sometimes a horizontal tear along with the radial tear. There can be a cyst along with it. There is usually some kind of a chondral pathology that is also there. So sometimes, so it's a mixture of all these things. And when you do an arthroscopy, then you are able to deal with all these things along with the alignment correction. But again, as I said, when you're talking about these degenerate knees with a virus, your main surgery is high table osteotomy. Because if you don't do high table osteotomy, then these things are not going to work. So I partially agree to that school of thought that you can do an osteotomy and get away with things. But if you have chondral things, chondral lesions as well, if you have other things that are associated with in an arthritic knee, then you might as well, if you're giving anesthesia to the patient, I might as well go in and see what is there and correct everything altogether at single point of time.
So you would want to do a root repair and HTO both if you see a root tear or a root avulsion.
So a root which is a fresh root tear with a virus, then definitely I would like to repair the tear. But if you see the recent literature and the experience that has been going on for the last 5 to 10 years, if it's an old tear which is irreparable, it's a retracted tear with maybe grade 2 arthritis, and you see the meniscal substance is not good, then sometimes you may actually leave it and do the alignment correction, and you will have equivalent results with that as well.
Yes. The only issue why I'm asking this question is that many of the people who are just starting doing STO, see, mainly now what has happened is the arthroscopy surgeons have started doing STO. Earlier, basically somebody else was doing STO. So
Right.
deformity surgeons were doing. So now what has happened is that people who are doing arthroscopy, they feel that it is too messy to do the root repair and STO together, especially in an obese patient. It is a
Right.
messy procedure. I mean, yeah,
Right.
there is too much things involved, too many things inside. What do you do first? So what is your
So
stepwise approach?
obese
You
patients
have
are
decided
always
to
a
do, so for
obese.
example, you have decided to
Yeah.
do a root repair and you have decided to do HDO. Now, what will be your step by step? What will you do first, second, third, and fourth?
So I'll tell you, obese patients are very tricky ball game here because in obese patients, even HTO sometimes is difficult in high BMI patients. Um, if the patient is really obese, then I will actually not repair root. Repair the root. I'll focus more on HTO because I want to get that particular thing right. Okay. The next thing is about the sequence of when you're doing both of them together. Okay. So once you do an osteotomy, until you fix the osteotomy, the knee is little stable. I don't want to play too much with the knee. So usually the tunnels and the bites are done first. So I take the bites and park the
No, no,
sutures.
let's go stepwise. Which
Yeah.
will you take the portals first or will you take the STO incision first? Let's start from there.
So the portals first, you do the complete examination of the joint, decide your plan. What are you going to do for that particular patient? Once that is done, all the chondral things and the meniscus things are completed. So you take the bite of the meniscus if you are doing a root repair, park the sutures and keep it ready. I usually drill the tunnel as well. Usually the tunnel changes in position when you do the osteotomy. That is a little bit of a challenge. But what you can do is you can keep a bead pin inside when you are doing the osteotomy so that it doesn't change too much or you're able to get it. But again, that is challenge because you are going to put the saw. So all these things are there. But the tunnel is made first. The tunnel is ready. After the tunnel is ready, then you do the osteotomy, complete the osteotomy, fix the osteotomy. and then you do the suture shuttling, because you cannot do suture shuttling prior to that, because when you're doing the osteotomy, it will get damaged. So that is the sequence. Sometimes I tie the threads to the plate because the plate, the the tunnels, or all are very near. So it's a little messy. I agree to you. But once you keep on doing it persistently, then you figure out a way to do that. But these are the
So there,
steps.
I have seen in Pune knee course very frequently. There are these some companies who have got these special plates where you can do a root repair, ACL and
Yes.
HTO, and there is a place in the plate where you can actually stick the suture disc or whatever. They only have something like a suture disc inbuilt where you
Right.
can tie the knots very easily. So
Right.
what is the common type of plates that you use?
So actually, it is not going to matter if you are able to use, because these are expensive plates. They are good plates. The kit that is provided is also good, and there's not no harm in using those plates. But even if you do with the standard plates or the Indian plates, there's no problem. You just have to decide, how to fix the root, and the tunnel management is such that where the osteotomy is going to be. You will initially make the tunnel so that it doesn't come in the way of the osteotomy.
If the person is just starting out and starting doing HTOs, he has already learned. What will
Yeah.
your advice be? Okay, what plate should he use? Should he use the Tomofix? Should he use the Arthrex? Should he use something else? Which is the easiest to use, with including the instrumentation?
Okay. So what happens is, generally the Tomofix was the gold standard some few years back. But in Indian patients, especially the female patients, these are very, very bulky plates. They have huge plates, uh, and you tend to feel them under your, because actually the middle part of the knee, or the shin, is palpable, and there's a huge plate sitting on it. So it is very, very uncomfortable for the patients. In huge patients, it's fine. It's not a problem usually. So I tend to generally use low profile plates, which are available. Multiple companies have it. It's there in Indian companies as well as the international companies. And that makes it a little easier because the plate is little malleable. The whole idea is to make it flush to the bone and maintain the osteotomy till the time it heals. That is the main idea of using a plate. A stable, angular, stable construct which is fixed and maintains the osteotomy. So yeah, again, I would say, you can take that call depending on your patient, the resources available, the finance available. All plates are good. But in cases of these smaller stature patients, try to use devices that won't create a problem, because the low profile plates will work better for your patients.
Name a few low profile plates.
So you have Nuclip has a plate. The Indian plates are also there. I think the Hip Surgical has a plate. Arthrex has a low profile plate. So the plate that you were talking about was the Nuclip plate. They are very good. They're very low profile, and they have all these fancy things, multiple polyaxial locking. They have a separate plate for ACL with root. They have a separate ACL with a uh, osteotomy. They have a separate plate for root repair with osteotomy. So you can use it to your advantage whenever you feel you have these complex kind of a scenarios.
Last question now. We finished with HTO, so now we go to UKR. When you said that there is sometimes you may have to do a UKR and a root tear. So
Yeah.
when will you do a root tear? Sorry, when will you do a UKR versus an HTO? How will you decide that?
So it's not very difficult actually. If you have a patient with grade 4 arthritis, a bone and bone arthritis with primarily because of a root tear not treated for a longer time, or a medial compartment arthritis leading to root tear. We don't know what happens first. It's like the egg or the chicken. But you have a grade 4 arthritis, bone and bone arthritis with a root tear. In such scenarios, I would go for a UKR, provided the lateral compartment is obviously, you have to know that the lateral compartment is okay, the ligaments are okay, then you can go for UKR. Vis-a-vis, if you have a patient who has maybe grade 2, grade 3 arthritis, and or a physiological virus, then I would in this scenario prefer to do an osteotomy over a UKR. So it again depends, because if you have a full thickness chondral defects, then kissing lesions on the femur and tibia, then the osteotomy will not work. you will get ligament correct, the alignment correction. The progression of the arthritis may reduce, the patient may be better, but they are never happy. So grade 4 lesions, bone on bone arthritis, lateral compartment intact, bad quality meniscus, degenerate meniscus, I think you should straight away go for partial knee replacements because they are extremely fast in getting back to their routine life and they are relatively painless. They have a good forgotten joint score. They do pretty well.
Okay, now let's talk about the last question. One more question has just come about the post-operative rehab. Say,
Right.
for example, if I'm doing three questions actually. If I'm doing only the root repair without the
Yes.
STO, if I'm doing HTO only or whatever, STO plus root repair. So what is the, I understand that UKR is immediate weight bearing, full weight bearing,
Yeah,
and
yeah.
when patient goes on the next day, they are comfortable.
So,
But it's like a TKR. But what about STO and root repair? Is the rehab different?
so what
Especially
happens?
the non-weight bearing part.
The rehab for osteotomy is much faster than root repair. So when you're talking about a scenario where there is root repair or a root repair plus osteotomy, then the rehab would stay the same because if the meniscus quality is not good, it's a degenerated joint, degenerate meniscus, then I would like to wait for minimum 4 weeks to start weight bearing because they are all fragile meniscus. The moment you put weight and they are not healed, they are going to tear off again. So minimum 4 weeks. If the meniscus is really bad, the tear and the arthritis is grade 2, grade 3, um, especially obese patients, then I may even wait for 6 weeks to start the weight bearing. The range of movement usually starts immediately because otherwise the knee gets very stiff. So I usually allow them to go by 45 up to 45 degrees in immediately after the surgery, and gradual progression is done. So say by 3 to 4 weeks, you move to 60 to 80. By 6 weeks, you go to 100 odd, and by 2 months, you try to get the full range. Partial weight bearing is for, as I said, 4 to 6 weeks. After that, maybe a month more, I'll keep them on a, sorry, nil weight bearing is for 4 to 6 weeks. And then for a month more, I'll keep them partial weight bearing. So the whole weight bearing, full weight bearing starts by around say 2.5 months.
That is for STO plus root repair.
Yes, because root repair, there is for root repair. So in a HTO, the rehab can be faster, in fact. But you have already done a root repair and a HTO. So for the root, I would like to protect.
Okay.
So it may
You
not
give
change.
them a long,
Or it may change for
you
an
give them a long.
isolated HTO. It may change for
So do
isolated.
you wait for the bone to heal? Do you wait for the see the proper callus healing only, then you give the full weight bearing?
Not necessary because I don't use a graft most commonly, and it takes a long time for that callus and the gap to fill. So, but I have not seen any collapse with the HTOs even if you start weight bearing. In fact, if you are doing an isolated HTO, you can immediately start partial weight bearing. If you are if you have good angle stable construct, you can immediately start partial weight bearing.
So there is one more question from a Ortho TV portal. It
Yeah.
is also related to portals. My question is, what portals will you prefer for viewing and working? That is taking sutures from the meniscus for medial and lateral root repairs.
Fine.
So I think
So,
there are two different questions. Which one, which portal for viewing and working in medial, and which portal for working and viewing in lateral?
right. So first thing is in all meniscus repairs, whether it is a root repair or a meniscal body repair or whatever, the portals are designed in such a way that the device should reach perpendicular to the repair area. So which is very easier in cases of meniscus posterior horn repairs because when you are doing a medial meniscus repair, your weaving portal is the lateral anterolateral portal, and your device comes to the anteromedial portal. Only when you are doing lateral repairs, if at all, because you have to cross the tibial eminence, it might be difficult for the device to come from the medial side to cross the eminence and cross the condyle and go behind. That can be a challenge. And at that particular scenario, you can just switch the portal, take your camera on the medial side, and use the device from the lateral side. But essentially, in scopy, whether it is a knee scopy or shoulder scopy, you put in your 18 gauge spinal needle, see what is the best angle of attack, from which particular portal you may reach the target easily. In case if you find difficulties, you can also take a transportal tunnel. additional portal, sorry, to take your bites and also for suture management.
Okay, I think that answers all the questions for tonight. We thank Dr. Abhishek Nerurkar for taking his time out and taking us to the directly to the root of the meniscus. That
Thank
is
you.
what we have learned, how to tackle the root tears. From a lot of variety of treatment is available, and it depends on the patient, and the BMI of the patient has to be taken into consideration before you offer any final treatment. And the most important is that do a scanogram always when you see a root tear, especially in a degenerative knee. So with this, we say bye-bye for tonight. We thank our supporters, Haleon, the makers of Centrum Joint and Mobility, to bring us this webinar. And we thank Dr. Abhishek Nerurkar. And we thank all our viewers to be there with us till the end. Thank you and good night.
Thank you, everybody. Good night.